Welcome back, everyone, to Med Talk RX podcast. Caitlin and I are excited to be back. We've taken a little bit of a break. We're laughing before we got on here. We prep for this stuff, y'all, but you just never like. There's so much that we could be talking about on each of these topics, and so we just kind of chuckle going into these that we don't know what's going to come out of our mouths
Nope,
on any of this
no
stuff.
idea.
No idea. But we were talking beforehand just to talk about different personal things that are going on. So I got a haircut today. If you're watching on YouTube, you can see, I guess, and leave in the comments if you like it or not. But I also grew out a beard, and my wife is not big on beards. She showed me a picture of the ideal beard, and it was what's that dude's name? Jason Statham, the dude that's on the action movies. You know what I'm talking about?
Oh, yes,
Yeah,
yes.
he's got
Uh-huh.
shaved head, and he's got
Shaved head and
like a
the
5
kind of
o'clock shadow. It's
right.
like it's not even a beard, it's just a 5 o'clock
No,
shadow that he's, like,
exactly.
shaved down. She's like, "This is what I want. This is what I think you look best with," and I'm like, "Well, that's what I always have
Yeah,
going."
yeah.
And so I was at the hairdresser. I was telling Caitlin this before we started up on this, and they were like, "All right, well, what do you want done?" And so I was showing them all these pictures, and I pulled up, like, Travis Kelce or something, and I'm like, "I don't want that short on top," but, like, you see how his beard's like this, but somewhere in between these 2 guys on their beard, and I was like, "But my wife likes it shorter, so maybe this," and the hairdresser was like, "Well, I'm gonna fade it, but I'm not cutting it all the way off because it looks too good," and I'm like, "Well, she may just differ on that one." And then Caitlin, you're like the Facebook,
Yeah,
like, YouTube short videos of women that, like, lose their stuff when their
yeah,
husbands shave their
yeah,
beard, right?
yeah, exactly. So it's happened twice, which I feel like that's a good number for being together for almost 8 years, so I'll take it.
Yeah.
I like the big beard. So he goes to kinda trim it, and he gets frustrated because he might nick it too, because he does his own, he'll like nick a spot. And all of a sudden, I'll hear cursing, and I'm, like, in slow motion, like, "No," because I know he's about to just ring, like,
He's like, "Well,
"Please,
here it is."
no." And it's super loud, and everybody's like, "Oh my gosh, is somebody dying in the house?" Like, "No, he's just about to
Mm,
shave his beard off. I gotta stop him."
just a beard trimming incident gone wrong.
Yeah. He's trying to do the Riley Green thing with the curly, longer
Oh,
hair,
yeah, yeah,
and yeah, not the
yeah,
stash. He did
not the
try to
stash.
talk me into that, and I was like, No."
Oh, I just look goofy with the mustache only. I shaved it off one time and just had the
Yeah.
mustache, and I was like, "Sarah, what do you think?" And I look like I'm trying to be like a Gen Zer or something, and it just doesn't work out right. It just looks cringy, it's
I don't
just
even want to imagine what Chase would look like. Nope,
I mean, I
just the
guess he
beard.
and I can shave we'll shave one time
Yeah.
and just leave the stash and take
Oh
one picture and
gosh.
then shave it all the way off
Oh
because
gosh.
it just yeah, it doesn't look good. Anyways, this is what we talk about before the
Yeah,
podcast.
pretty much. Yep.
Yeah, not always what we're talking about on the podcast, but this is our like, we catch up
Yeah.
beforehand, and Caitlin and I genuinely get along, and so we laugh at each other's family dynamics and everything that's going on, and our kids. We always
Uh-huh.
are talking about the kids. She's got
Yep.
a sassy daughter. I've got a sassy
Sassy.
daughter.
Yep.
Goodness, I mean, I don't know if you're listening in and you have parenting advice, send it. I mean,
Yes,
because
please.
I
Please.
don't know what people, like, think going into parenting, but I thought, like,
Not
I got this figured out, right?
mm,
And then we start parenting, and I realize every single day I fly by the seat of my pants.
oh, yeah.
Like,
Yeah.
I mean, run around the house, get some energy out, every time
Right.
you run
Yeah.
by me, say, "Hey, dad, I respect you." Something like that, like, it's
Yeah.
something new every day that I'm trying to do to get
Yeah.
them to listen, number 1,
Oh, yeah.
and
That's
try
a
to
really
obey.
bad situation in the house right now. It's like we get out of the terrible 2s and we go into 3s, and I'm like, "Oh, okay. We're
Mhm.
starting to learn control. Oh, no, we learned how to talk now. This is not good." So now her
Yeah,
big thing is, "Please stop." And I'm like, "Oh my gosh."
and
Like,
where they get these things. Yeah,
no.
my son told me today, he runs in, and I've been griping about something when I was getting ready. He runs in to the bathroom, he looks right at me, square in the face and he says, "Dad, get yourself together."
Don't you love it
I'm
when
like,
they, like, they use your stuff back on
"Yeah."
you? Yeah.
I'm like, "Who do you
He was
think you
like, "Stop
are?"
aggravating me." I'm like, "Oh my god."
Yeah, and then my daughter is the master debater, like, she will debate you
Yeah.
on anything. I mean, it could be
Yeah.
the sky is blue, she's, "No, it's purple today, Dad, I was you're just blind," or, I mean, it's just like, I
Yeah.
mean,
Right.
she will argue with you. It's just like, "Girl, this is what gets you in trouble, like, listen
Right.
at you," like,
Yep. That's
goodness.
what we tell Ava. We're like, "If you would just listen to us the first 5 times, you
Yeah.
wouldn't get in trouble."
I mean, I'm hoping the strong will comes in handy for those girls
No.
one day.
Yeah, that's what we say. Yep.
My
Just
son, on the other hand, is a pretty good rule follower. He's the one that will say, like, "Hey, mom, I'm really sorry sister's not listening to you." I mean, he's like 4 years old and he's apologizing for her, and he's the, kind-hearted one and the
Yeah.
non-argumentative one, mama's boy.
Yeah.
She's a daddy's girl, but, she still doesn't listen to me real well, so we're working on that.
That's how she is with Chase. She's a daddy's girl, but
Yeah, I don't that
no.
goes out the window in terms of,
Yeah.
like, whether they're gonna
Yeah.
listen or not on
They'll have a
that.
10-minute argument about you have to wear your jacket because it's cold outside. They get
Mhm.
outside, and within a minute, the jacket's off, and he just
Yeah,
lets it go. I'm like,
throwing it
"See,
on the ground. Yeah.
this is why."
Be freezing, and she's like, "I'm not gonna lose this,
She's
dad."
like, "I'm not cold." I'm like, "Oh, your arms feel like icicles."
Yeah, you're shaking, but that's evidently
"But
not
I'm not cold."
indication.
I'm like, "Okie
Yeah.
dokie."
Well, anyways, we hope that you guys will send us parenting advice because we would
Yeah.
take everything, anything and everything. Today, though, we are talking about something that I think is very interesting. This is seen across the nation, this topic of pharmacy F tags that you see in the long term care skilled nursing facility space that we're in, that we provide services to. There's a really interesting website out there. I think it's very handy. It's called ProPublica, and there's a lot of uses of it in various ways. But one of the sites on ProPublica actually takes and consolidates 2567's nursing home deficiency data across the nation for time periods. It breaks it up by state. Really, really useful tool if you haven't ever messed around with it at all. We'll try to put a link to it if Caitlin doesn't let me forget about it. We'll try to put a link to it in our show notes because I think it's very handy. For example, if you were in Texas and you wanted to see what deficiencies have been happening up to at current date. It lags a little bit behind, obviously, but pretty current date, within that given year, you can see for Texas what deficiencies in long term care facilities have happened during that period of time during the year. So it can be helpful to understand what your fellow sister facilities are seeing across the state. But we took ProPublica and with the help of AI, because everybody's using AI nowadays, and it's not always accurate, just plug that out there
Yeah.
for, speak it into the universe because it is not 100% accurate. You have to vet that stuff out pretty heavily. But we took it, downloaded all the pharmacy tags up through, I think it was last week when we ran the data, and I plugged it into AI and had it calculate how many deficiencies on pharmacy side F tags, how many occurrences there were. And the top ones that we are going to talk about today are F761, which deals with labeling and storage of medications, F755, and F760. And Caitlin and I are going to go into a little bit of details about some of the things that we see because when we read this list, and then we'll talk about the ones that are kind of following those in terms of counts. But when we read this list, Caitlin and I immediately went, "Yep, we've seen that this year. Yep, we've seen that this year." Some of the other ones that we see, F756, drug regimen review, 57, unnecessary meds, and then 759, which deals with med error rates. Those are the other ones that were primarily seen across the nation. So, as a long term care facility, if you're listening in on this, F761 was the top deficiency seen across the nation up to this point in time. Closely behind that was 755, the pharmacy services tag, and then 760, which was the significant med error tag. So, those are the 3 that we're gonna primarily spend time with, but we may have a little bit of time that we're gonna jump into the other ones. If you are wondering kind of the state breakdown in terms of, like, well, how often or which states are the ones that are getting the most deficiencies? The ones that would be categorized as kind of the states with the most would be California, Texas, Pennsylvania, Wisconsin. Those are currently the highest ones. And then North Carolina, Missouri, Ohio, Indiana, Illinois, Kansas were the next in line. So if you're in one of those states, just know that your survey teams are tagging pretty heavy in comparison to the rest of the nation. So when you listen to these things, put this to memory. Ask questions in our comment sections on YouTube or whatever your favorite platform is. Our contact info is at the end of each of the podcasts, so you can reach out to Caitlin and I directly. We are happy to answer any questions for you, or stumble through answering questions for you, depending on what it is. Um, but with that, let's kick this off and let's talk, Caitlin, about 761, which deals with
Okay.
the labeling of and storage of medications. I mean,
Yeah.
we see this all the time.
Oh, yeah. All the time.
Yeah, I would say some of the big ones, obviously, shortened expiration dates are a huge issue in
Huge.
the
That's probably
long-term
the
care space.
biggest out of
And
this one for me.
yeah, and I would say, Caitlin, and I don't know what you see out in that area, but at least what I have seen is as a nurse or even a medication aid or whatever, y'all are juggling a lot of different responsibilities, tasks, things like that. And remembering to date things when you pull them out is it seems like one of the biggest hurdles to overcome in the
Yeah.
long term care space. And I think it may seem kind of straightforward when you say it just out loud and you say, well, all you need to do is label it when you pull it from the fridge or whatever. But I mean, I think about like at home, if every time I pulled a milk carton out or something like that, I had to write a date on it, there's
Right.
many times I would probably forget to do that because I would be bombarded by a patient at the time or something like
Exactly.
that. If that was, or at home, it'd be my kids. I'd be sitting there trying to get breakfast ready and I would forget to write a date on there. So it's very common to miss some of these,
Mhm.
but there are many medications that have shortened expiration dates once you pull them out of their original containers. Caitlin and I've talked about this before on the podcast. A bunch of our YouTube shorts have these in there as well. Things like albuterol, ipratropium, nebulizers, those have shortened expiration dates. Inhalers in general have shortened expiration dates. We see those hardly ever dated when they're opened.
Yeah. Right.
And so you take Caitlin, like I'm thinking of Advair
Mm.
Discus, right?
Yeah.
And we won't even get into all the like, well, can a patient actually take those? Can a resident actually take those appropriately when they're 85 years old? Who knows? I mean, maybe some do, maybe some don't. But in general, those Advair Discus are only good for a month once you pull them out of the foil.
Right, and that powder starts to disintegrate. I think
Right,
that that's there are some medications that, like, we know that probably have a longer shelf life. But there are genuinely some that do not because they're
right,
not made for that type of stability in that form of the drug, whether it's a powder or it's a liquid. And some forms are more vulnerable to environmental factors than other forms. With the nebulizer full packs, they're very sensitive to moisture and light. So that's when that full pack is open and you expose it to moisture and light, even though they're in a dark drawer, that might help, but you don't know how much moisture is in there, and it's just a sensitive drug form. And it is difficult. It's part of our regular med cart and why we get so heavily involved in doing med carts in the facilities, because this is a very tedious day to day, watch list. And it's just like the analogy, you're talking about with the refrigerator. You also have other people in the house coming into your refrigerator. Same thing with skilled
mhm,
facilities, right? So it's not the same nurse every time. It may be a different nurse every time on that cart because they may rotate that specific cart between agency or part-time or what have you. So a nurse can come in and have it looking great and then nighttime shift because there's meds only at nighttime. They take Atlantis out of the fridge and not date it. Then that nurse may not come back for 2 or 3 days because they've had the weekend off. And then there you go. They come in on a Monday. Everybody, I think, can agree that Mondays a lot of times are one of your busiest days because you're playing catch ups and they're doing the
oh yeah,
exact same thing. So it is tedious, it's difficult. But another there are other, like, meds, even, like, as I was checking the carts that I didn't even think about, which may be silly, like lidocaine vials.
Yeah.
Those have to be dated. Any type of multi-dose vial has to be dated that's on the cart. Making sure that meds that should be refrigerated stay in the refrigerator, like in the med rooms. Like, a lot of times, there's a misconception about what eye drops can go in the refrigerators and what cannot. So, you have dating things to know when they come expired, making sure you pull them off when they become expired. So that can be a double-edged sword because you can tell on yourself, right? So there's a second step to that. And then there's also where the meds should be stored per manufacturer specifications. There's just a lot of things that go into that. We have so many drugs on the market. And I feel like that's probably why this is the most common one that we would see with tags throughout the United States because there is a lot that goes into it. Doesn't sound like a lot, but it is when you're dealing with all the things that they're having to deal on a day-to-day basis and so many different hands in that pot to try to keep up with and make it the way it should be.
Yeah, it definitely requires a lot of intentionality. There has to be a plan in place. And this is where, as pharmacy consultants, we oftentimes come in and we're not there to just, tattle on you or whatever when we find
Right.
this stuff. We're there to educate and to help you. That's the real purpose behind it, but also to help you establish systems to be able to look for these things on your own. We're not there every single day of the month. You are. And at the end of the day, we are in this together to provide good resident care. And this is part of that resident care, right? And so, like Caitlin was saying, it's very easy to miss these things because there are so many of them. I was thinking when you were talking about OTC eye drops. I mean, how many of those things, well, these are
Right.
preservative free. So those go out in a month. These have preservatives. So they're good for the
Mhm.
expiration date on the box. So there's even things like that. Or there may even be individual company policies that dictate that those products, those OTCs are thrown out earlier than when the manufacturer even suggests or something like that. So you need to follow that policy. And that's where I think it takes a team effort on this to educate one another on insulins, on eye drops, on all these inhalers and things that those are by the way, those three areas are the biggest ones that we see problems with: insulin, eye drops, and inhalers
Yeah.
with dating and shortened expiration dates.
Yeah.
Insulin primarily, and like Caitlin was saying, the other thing is knowing how they're stored. It's not always straightforward because you as a nurse or a caregiver, may not know that medication because you've never had it yourself, never had a loved one that's had it. And then there's also the whole, well, insurance dictates how much we dispense on some of this stuff. So the insulin, there may be 5 pins that come out with that order
Yeah.
because that's what
Mhm.
insurance wants to approve, right? Well, you can't put all 5 pins on the card. They'll all expire at room
Mhm.
temperature after
Mhm.
30, 40, 2 days or whatever. And so we have to be really diligent and intentional as a team, both the consultant pharmacist or consulting nursing staff,
Yep.
as well as your teams in the facility to find a system that works, that is independent of just one party looking into that can be happening day in and day out. And like Caitlin was saying, maybe the night nurse is the one that pulls it and they
Mhm.
forget to date it. Well, then they don't come back for 4 or 5 days. Well,
Yep.
if it's an insulin and it was dispensed last month, but there's this huge supply of it, well, it may look like it's expired. And so nobody's going to know unless it's dated. So that intentional practice and establishing protocols and standards as to how, as a facility, you're going to handle dating and labeling and storing is really important. This is also the deficiency that includes controlled substances and double locking controlled substances. This has been like an epic debate with CMS for, like, I feel like decades as to, well, does a med room count as one lock, that med room door or
Yeah.
not? Or
Right.
does it need to have 2 locks, one on the
2
outside of the
locks.
fridge, one on the
Yep.
inside of the fridge?
Right.
And that's why our medication carts are designed the way that they are, with one lock on the outside and then one lock on the narcotic drawer. That is a regulation. If you didn't know that, that controlled substances remain under double lock, even when we're getting ready to destroy them. whether or not that's involving your consultant pharmacist or just involving your facility staff and witnesses, they still have to remain under double lock until they're destroyed. And so this is also the tag that we see that coming up from time to time where state comes in, your bedroom door's wide open, they walk in and realize that the fridge doesn't have a lock on it. So now it's only single locked and they're going to tag you an F761 for a failure to just to store appropriately those controlled substances. So
And
very
some
interesting
facilities
tag. Oh, go
sorry,
ahead.
Scott.
No, go ahead.
Some facilities, which I didn't know this, and this is just kind of one of those things you learn as you go, but they had a lock drawer, like, it's like one of those lock drawers that you typically see like in a cashier's drawer, but
Yeah,
it was in the refrigerator, but it was able to be removed. So it wasn't screwed into the
right.
refrigerator to where it was, locked like in place, right? Physically. And that got a tag because that didn't count to CMS because somebody could just take that lock box and just walk out the door. So that was not a
Yep.
secure lock. And, you talking about that just kind of jarred my memory,
Yeah.
that happening. And it was like when I first became a consultant. So, that immediately went on my radar that when I'm checking the refrigerator, are they secure locks where I can't take it and move it out of the refrigerator, not a lock box, you know?
Yeah, and that comes up a lot. I remember, anytime I'm doing training and stuff and we go in a med room, I try to point that out because it's really easy. So a good example of that would be that you adhere the lock box to a shelf, but the
Hmm.
shelf is also removable. So if that's the case, they can just pull the whole shelf out. Now, granted,
Right.
I'm hoping that somebody notices carrying a whole
Right.
shelf with a narcotic box stuck to it. Maybe nobody does or whatever, but still it should be adhered, and that's why you see them bolting the chains on,
Bolton.
to the side of the refrigerator. It gets kinda
Right.
crazy in this setting
Yeah.
that we have to do all this, but
Right.
it's all to prevent diversion and all
Mhm.
that kinda stuff. But Caitlin's exactly right. That's another huge area that we see, from a storage and compliance to storage standpoint. So, anything else, Caitlin, that we forgot? I mean, there's so much more to that deficiency, and that we could spend all day just talking about that. But anything else you wanted to mention on there?
Other than don't leave, med room doors propped open, that only authorized personnel have access to the keys. So I read that a lot, just kind of refreshing my memory over the years, just kind
Mhm.
of with this tag. And I never really had to apply it until recently. And I was like, well, that's where that's applicable. So in some facilities, they may have like a separate, they call it like not a med storage, but a unit storage area where they put overflow of med supplies and, they may be diapers and nutritional things in a room. And they will put OTC products or meds that are overflow, unknown to the consultant pharmacist. Well, not only do nurses have access to that area, but maintenance people may as well. So it's just something to kind of like keep in your mind that knowing where all medications are stored and who has access points to those rooms outside of if there is a universal area or room outside of med rooms. That little statement right there can come into play and you didn't really think about it and it just kind of sneaks up on you. So it's just
Yeah.
something to think about.
Oh, one other one that we didn't even mention is refrigerators. I mean, we mentioned refrigerators, but the temperature
Oh,
logs,
yes, the
that's a
temperature logs,
huge
yeah.
one.
Yeah,
Um,
that is a big one.
yeah, and a lot of times we see the temp logs with one recording on there. I think according to CDC, if you store vaccines in your fridge, they really recommend twice a day, but if nothing else, at least daily temp log
Mhm.
checks. And we see lots of issues with that.
Yeah, we do
It's
too.
easy to forget. I mean, it's one of those, like, you have to do it every single day, so you would think, "Oh, well, if it has to be done every single day, then that should develop into a habit." Sure, but you don't have consistent
Right,
staff every single shift, every single
right,
day,
right.
so that may be a habit for some, but newer nursing staff or people that are documenting on those temp logs may not remember that. And then just a lot of times we'll walk in, and if you look in the fridge, obviously in the setting that we're in, if you're storing vaccines, you really need to not have a dorm style refrigerator, the typical ones where a freezer's on top
Mhm.
and it's not separated. It's just up
Right.
in the very top because there's
It
a huge
causes
fluctuation. right, and
Yeah,
temp.
it does. Yeah.
And if you put anything next to that thing, it'll freeze solid. So you
Yeah,
put vaccines, anything, insulin, it'll freeze
up there
solid.
at
So
the
you
top.
really need the separate if at all and they actually make dorm style fridges now that are separate. Like you
Yeah.
have a freezer up top and then a which I don't really know what all you're putting in the freezer, but freezer refrigerator deal. But long story short, sometimes I would walk in there, a lot of times I would walk in there to a home that had that same dorm style fridge for, decade or whatever, and which is a miracle it's still working the way that it
Right.
used to. They just don't make things like they used to. But you'd look in the freezer part up top and have this big wedge of ice. If you see
Yes.
that or on the back of the fridge, some of those medical
Yes.
fridges, you
Yeah.
gotta defrost that thing because that thing will be all fluctuating like crazy on temperature. So, things like that, and if you get your consultant pharmacist in your building and they're saying something like, "You need to defrost your fridge," or "You need to document your temp logs," we know it's a nuisance. We know it's annoying to hear that over and over again, but the reason is because 761 is an easy tag to cite. In fact, it's the
Mhm.
most commonly cited tag up to right now in the nation. And so, yeah, just
Yeah.
listen to us. We're not trying to be nitpicky. We're really trying to help you out and help you avoid deficiencies. Moving on, 755 is pharmacy services. And this one is one that um, here at PharmCare, we're a pharmacy and we're a consulting group as well. We really have to work together on this because and along with you guys in the home, just to make sure that people always have their medications. Ordering medications, it seems like, okay, everybody should just order meds, but again, I mean, I'm thinking of all of us that are just out in the public. I mean, how many times do we forget to call in a refill on our own meds, let
Right.
alone other people's meds, maybe 20,
Mhm.
30 patients or residents worth of meds? So it is an easy thing to miss, or maybe you have every intention to reorder meds and then you get bombarded with something else. Emergency happens or something, and you just forget all about it. So, this is a deficiency that we see quite often when it comes to just not having meds available in the building. It can be things ranging from the two big ones, which would be antibiotics and pain meds, are the two
Yep.
really big ones. And we'll see those come into play on the significant med error section and deficiency that's coming up next. But this is one where it also incorporates in the consultant pharmacist. If you didn't know this, we are a regulatory requirement. That's 48345B on, and that's gibberish sounding to most people, but 483 45 is pharmacy services. B is a subtitle B, and that is where it talks about where we are a requirement to have a licensed pharmacist that's employed by the facility, and we consult all aspects of the building. But it also incorporates all of the does your resident have all the meds that they need? Is there a plan in place? And that is where your consultant pharmacist, if they didn't know this, they should. They're also supposed to be working with you to establish systems in place for when there are problems. So, for example, if you are noticing that your team is not ordering medications, bounce off ideas amongst yourselves and the consultant pharmacist and say, what can we do? How can we work better with your pharmacy to ensure that meds get into the building? And then let us kind of help you and guide you in that what we've seen work, what we've seen not work. But this is another huge one that we see, and it's just because it's very easy to forget to order a med. Not only that, Caitlin and I were just talking about this before the call as well. Insurance
Mhm.
is ridiculous nowadays.
Yeah.
And you have some plans out there that you have to fulfill 90 something percent of the medication use before they'll issue a refill. Sometimes that's 2 days remaining. That doesn't give you a lot of wiggle room on there. And
No.
so this is the deficiency that is second to the labeling and the storage. And it's pretty obvious why. There's a lot that goes into pharmacy services. Although we are just the medication aspect of the resident care, it's so much more than that to make sure that their meds are in the building, and it's a huge part of their overall care. And so that's the second top one. I mean, this tag is so massive.
It
There's a
is.
ton that goes into it. But Caitlin, anything that you want to add to that one?
Just piggyback on what you said, I think the biggest one I've seen is pain, and I think the reason for that is that maybe Opioids have certain requirements when it comes to dispensing, and sometimes if those strict requirements are not met by the physician and pharmacy, you do have a gap of dispensing and getting out. Sometimes that does happen, but this has been the biggest one I've seen is been with opioids not getting in the building fast enough, and, the staff not following up on it and getting what they need, like, either from the hospice or from the regular, primary MD of the facility, and it just kinda being at, unfortunately, a stall 'cause, they're busy too. They don't just have 1 resident, they have several, and they may send in a script and they're like, "Okay, I'm done," and they don't think anything else about it after that, but they left a quantity off or they left off something that the pharmacy has to have, or the insurance rejected it, or they rejected some part of the prescription. So that has been a big one I've seen is pain, almost to the point to where state goes and sniffs it immediately.
Yeah,
Yeah.
yeah. And it is. I mean, it's a huge one. Nobody wants any of their loved ones to be in pain.
No.
And nobody's setting out, I don't think, with the intention to cause anybody to be in pain.
Mm-mm.
It's a very difficult system, like Caitlin mentioned, when you have
Yeah.
e-prescribing and triplicates and things like that that are now involved, and you've got to have really good communication. And that's what we're here, obviously, as the consultants, as your pharmacy providers, to do, is to work with you guys to help you understand perhaps some of the challenges that we might be facing to get those medications out to you, and that are going to potentially have that person be without pain meds or something like that because of a breakdown in communication or something on that end. And that's why we have to work together as an interdisciplinary team. But yeah, pain meds, antibiotics are another huge one. It requires a lot of good communication because we're trying to get that antibiotic order out. Could be a very high power IV antibiotic
Yeah.
coming out of the hospital, right?
Yeah.
And we need to get it there before their next dose. So
Mhm.
there's a whole lot of communication that has to happen so
Yeah.
that we know, like, when did they get their last dose, and we're going to try to get that out as quick as we can so that they've got it ready for them. And so there's just so many moving parts on the medication aspect, and that's not even accounting all the, did you guys click the reorder button, or there's all sorts of issues with interfaces out there, and did it get checked in properly, and can it be reordered? And so there's all these nuance, intricate pieces to this overall process that requires a lot of interdisciplinary collaboration, I think, to make sure the meds get there. And that's what we're here to help you do. So obviously, if we notice when we're auditing a med card or something that meds are missing, or we're watching a med pass and meds are not available, then we're going to be working with your homes to determine the why behind that
Mhm.
and see if we can figure out a better system for that. And that brings us into 760, which is a unique tag. And I was telling Caitlin this because the way that it's worded, it's a very unique tag. And it is the one that talks about being free from any significant medication errors. And you might be thinking, well, aren't they all significant? Well, not according to CMS. They're not all significant.
Right. Yeah.
There are some that are very significant, and then there are some that
Mhm.
are not significant med errors. And what complicates this one even more, I mean, I just printed out the whole regulation right here and highlighted it to bring up a couple of things to you guys. What complicates it even more is that it deals with the judgment, the professional judgment of the surveyor in a lot of ways. And so it may be a med error, and you may have somebody that goes, okay, well, that is a significant one, or that is not a significant one. So hopefully, what we talk about here in a second will help you out with that. One of the first things that I think we need to mention, and this goes along with 759, which is one of the other top deficiencies seen across the nation. That's the med error rate is more than 5%. What we're talking about there is on med pass. So as you are doing a med pass in your facilities, if they watch 25 meds and you do the math on that, that's one med error is all that you can have. And so Caitlin, remind our audience here what a med error is, because it's not everything is a med error. Sometimes this is really confusing even for consultants. They'll be like watching a med pass and they'll go, "Oh, didn't wash their hands. That's a med." No, that's not a med error. That's infection control. There's so many things that happen here
Right.
on this, but remind our audience what a med error actually is.
Yeah. So the stuff that I have been exposed to during state surveys, one would be right dose. So
Mhm.
we had a vitamin D, and vitamin D's come in like IUs or micrograms, and nurse got confused, put two, thinking that it was the right dose, but it should have been one. So that was a med error. Not giving a medication specified to physician orders. So if they say give it after a meal, before a meal, that's a med error. Not following manufacturer specifications, that's a mid-air. So if the manufacturer says, "Hey, we need you to mix this with 10 milliliters of water, let it sit for 15 minutes before administering and on an empty stomach," and you don't follow all of those directions, that's a mid-air. And that's very tedious, and that has come up. Another one, I do believe, correct me if I'm wrong, if we crush it and the manufacturer said do not crush or it cannot be crushed, right? Yeah. That's a med
Yeah.
errors. And that's another one of those things like with the manufacturer specifications, it's really difficult for nursing and for staff and management to keep up with because these patients are on a lot of medications, but they also change medications and they also get new residents in. So there may be medications that come in that this person's been on that they're not familiar with, and there's no indication about do not crush, or it may not have CR, ER at the end of it, and it's just not that blinking light that we're all used to, and just state comes in and, that's how we find out, unfortunately. But that is a med error. It's difficult to juggle all of that and know all those things. Insulin administration, if it's not done per manufacturer specifications, that's a med error, like priming the insulin and following the directions to the T. So those are the main ones that I see. Kind of how I understand this tag is are we not following the professional standards in medication administration, meaning from a manufacturer, from a physician, and is it not being done safely, and is it not exactly the way the order was wrote? And
Yep.
that's kind of how I group it together to simplify for me personally to kind of understand when I'm watching these things and I'm educating.
Yeah, and that's exactly right. So when you're looking at the med errors, that's exactly how Caitlin was describing. Those things are all med errors. There's nuances, there's subtle nuances to those, especially with the crush meds, and we'll talk about that in a second. But the significant med error is different in that you're basically saying this is a med error in which it's going to cause extreme resident discomfort or it's going
Mhm.
to jeopardize their health and safety. And so
Right.
you have to think of this as like, okay, this would be like the king of med errors, right? This is the ones that you want to
Mhm.
really avoid. You want to avoid all med errors, but you definitely don't want to do one that's going to cause discomfort or harm or the potential for harm, because that again is going to result in their potential decline or things like that. It could be
Yeah.
as simple as not giving laxatives to somebody that's on opioid medications. The risk of
Mhm.
impaction goes through the
Mhm.
roof whenever you've got a bunch of anticholinergic burden, which we'll have another podcast at some point talking about that. But whenever that's happening, it can be something that what seemingly is innocent or simple could be
Right.
seen as a significant
Matter.
mitter.
Wrong
And then,
resident.
yeah, wrong resident. That's
Wrong resident.
happened a lot. So
That
again,
happens. It does. Yeah.
we've talked about this on the podcast. Don't set your meds up, because if you set them up in a cup and you grab the wrong cup,
Mhm.
tons of significant med errors right there, immediate jeopardy tags, different things like that that are going to be finding your way on those. And what's important to note about this is that these are two separate tags. So we mentioned med errors. That's 759, and that really deals with whether or not they have 5% or you guys have 5% or more med errors on
Error.
your med
Mhm.
pass. Now remember, on med pass they're looking at 20, at least 25 different administrations of various types. So they're not all going to look at oral, they're going to look at insulin administration, nasal, ear, otic, rectal, like all different types of administration. And G tubes, we'll come to G tubes in a second. Those are another huge beast in of themselves. But when we think about this, they're two separate tags. You got 759 and you got 760. Well, 759, irregardless of whether or not you're 5% or more, 760 can still be tagged as a
Right.
significant med error, right? So I think that's important to remember. There's primary areas that I think help determine whether or not it's a significant or it's a non-significant med error. And those three areas are the resident's condition, the drug category, and then the frequency of the error occurring. And so when we talk about the resident's condition, they give a really good example in Appendix PP. I believe the critical element pathway also gives a pretty good example as well. But they say in here, like, for example, you have a diuretic that is, or some people call it a fluid pill, right? But a diuretic that is administered to a dehydrated patient, well, that could be a significant med error
Mid-air.
because the
Mhm.
person's dehydrated, you're pulling
Mm.
more fluid off of them.
Or
But
low
now, if you,
pulse, and we give
yeah, low
metoprolol.
pulse could compromise their overall health. But then you flip the script, and so now you give that same diuretic pill to somebody with normal fluid balance.
It's
I mean,
not.
not that big of a deal, right?
Mhm.
That's designed for that kind of a patient. So again, the resident's condition, where they find themselves, the acuity of their care, the comorbidities that they have, things like that, are going to determine significance at time.
Yes.
Drug category. So really, what we're talking about here are a lot of the narrow therapeutic index drugs. You don't hear about those as much, but those are your digoxins, warfarins, different things like that that have a very narrow therapeutic index, meaning that they have a little window of area where they have to stay within to be effective. And you get outside of that, you get into problems with that or potential problems. I shouldn't say you're going to have problems, but potential for problems when you get outside of that. And so we're talking about drugs like phenytoin or dilantin. This one comes up throughout the regulations. You see it here. You see it with shaking when you talk about dilantin suspension. You see it with um, it could be significant based on the dosage form that you're using of Dilantin. Some are delayed release, some are not. So you have all these different kinds of areas where it appears. Feeds, like pausing feeds with intral feedings and G tube administration. It appears throughout all of them. So familiarize yourself with Dilantin because it pops up all over the place. It is used a lot. It has to stay within a serum concentration of, I think, 10 to 20. So
Mhm.
and then and here's a freebie that we won't really get into breaking down right now. But if you've ever looked online, there's calculators to calculate the
Yep.
dilantin level of somebody with low albumin. It is albumin adjusted. And so
Mhm.
you may think that you're in the right range, but their albumin could be in the tank and they're actually way higher on their concentration than what it shows on the lab results. So
Right.
that's where your consultant pharmacist comes in there. But dilantin, carbamazepine, warfarin, we don't see warfarin as much anymore. Back
Mm-mm.
when I first started, we saw it all the time, and it is such a nasty drug to interact with so many different things. A DIG, which I mentioned before, old drug, but
Yeah.
still used. I feel like in this population, I think they're kind of moving away from it in the main heart failure stage now for most patients. Theophylline, Theodore, it's older drug. Again, it's a very narrow therapeutic index drug as well. And then lithium. Lithium is
Oh, yeah.
used to be kind of a
You have
gold.
to
I
watch that
don't.
one.
It may still be the gold standard for bipolar. I can't remember if they've changed up that or not. But
I think they have, but I do see a lot of, like, older residents be on that because that's what they were stabilized on.
yeah, yeah.
So, and then sometimes, the when we get older, we're less likely to respond to maybe some of the more first line therapies. So I'll see them have to use lithium.
I'm wanting to say this is a random tidbit of info, but I used to go out and consult in Texas in a place called Mineral Wells, Texas. And I
Hmm.
believe out in that area, they used to bottle water out there and they would use it for certain conditions. And then when they found out why it had lithium in the water,
No kidding.
and so that was why it worked
Yeah,
for certain. I mean, people were in
certain.
just great moods out there all the time.
Yeah.
But yeah, that's so drug category. So you had resident condition, drug that's drug category. So your narrow therapeutic index drugs. That's like a tongue
Hmm.
twister. And then the last one's frequency of error. So something that happens
Right.
a lot
A
would
lot.
be a
Yeah.
potential for a
Like
significant
there's a lack of
matter.
procedure. Like
Right.
we don't have good policies and procedures in place.
Yeah. So I wanted to talk about some examples that they give from CMS because I think this helps kind of understand maybe in some ways what is
Hmm.
significant and what's not significant.
Yeah.
And they break it down. I think this is really nice. They break it down in all these tables and they give you an example of what is happening in the scenario. So this first one is an omission. So you forget to give the med, basically, or you don't have it to give, one or the other, which then comes into the pharmacy services deal. And Caitlin and I were talking about this before. If you're listening in, have you ever heard of the domino effect where, like when you have dominoes stacked up and you hit one and they all kind of start falling down, right? That is in long term care. That's what is used to describe when you take one deficiency and then it kind of bleeds over into another area, and that's a deficiency. So you might have one problem end up being multiple tags. If you work in or have worked in long term care for a while and you're thinking, oh, yeah, I remember that. We had one thing happen and it turned into two, three tags. That's the domino effects. Again, failure to give the med because you didn't order the med or it wasn't in the building for whatever reason, insurance, PA, whatever. Uh, an example they give here would be like metoprolol or furosemide. Those would be significant if you did not give those. And obviously, you can think
Right.
about heart rate, blood
Mhm.
pressure control, etc. What would not be significant would be like trazodone at night, and that would be for sleep when it was given in that way. Not giving artificial tears,
Right.
maybe an ibuprofen, not given fiber supplement, just like a normal routine,
Yeah.
multivitamin, calcium carbonate, those kinds of things would not be significant, but metoprolol, furosemide would be. So that would be an omission one. Any thoughts
That
there,
makes
Caitlin?
sense. Huh?
I said, any thoughts there? I had to get a drink, so I wanted to see if I could
Sorry.
plug the drink with some coffee. All right.
It's
So
just a habit, huh?
yeah, huh? What?
Yeah.
Yeah. That's a
Living
that's
with
a
a 7-year-old my so we live with my parents right now, and
yeah.
that is just his main vocabulary, "Huh?"
Huh?
And it's just like across like even my daughter, "What? Huh?" I'm
Huh?
like, "Oh, no."
What has
It is
happened?
contagious. Yeah. Yeah, so I'll piggyback off that. So the medications in the class of which they are in and what they're being used for and what they are benefiting the resident will substantially impact the weight of that tag or whether it's significant or not significant. So if you can imagine somebody missing a dose for a med that's being used to control something that in their body is not working well or is malfunctioning, and if they don't have that, it hurts them, then it would be a significant issue. Another thing, like he's talking about the domino effect. I have seen where they look at control count sheets and they'll see like a nurse will count a half tab. If the order says half tab, they'll count the half tab as one, whereas another nurse will count it as one half. And they'll get confused at what dose they're giving and then watch the med pass and see there's inconsistencies of who's giving what dose. And then there you have that domino effect of like, okay, we have a med error, but then throughout the entire building, we don't have consistencies of how we're counting down controls and how we are giving confusing
Right.
doses. And that can transpire into other issues. And that's kind of where sometimes not having secured policies and procedures and education with staff throughout the building of having a one system in certain situations can cause these types of tags to rack up very easily.
Yeah.
And that is easily seen under the radar. But yeah, this one, it's a big one, and it's one I get a lot of phone calls from state of, "What do you think about this?" And, "Well,
Mhm.
this person, they took it this way or they didn't get it. What is the side effects of that?" Or they gave it when the heart rate was at too low or the blood pressure was too low, but they gave it anyways. You'll get a lot of questions about that, and that's essentially, pertaining to this tag.
Yeah. And there's so many things that can happen. I mean, the examples that they give, an unauthorized med, meaning that a med that was given without an order. Obviously, if
Yes,
you
that's
give,
happened.
yeah, it's happened before. Warfarin, moxicillin, allopurinol, all of those are considered to be significant in the state's eyes. Now, if you gave somebody an acetaminophen or a ferrous sulfate, not significant. still
Mhm.
med error, but
Right.
would not be a significant one versus non. Wrong dose, giving 0.125 of dig instead of 0.25, or giving the wrong amount of morphine, obviously for good reasons. Giving the wrong amount of a pain med, especially something like morphine, can be very detrimental. And then just like things like wrong route of administration, you're given an eye drop in the wrong eye. Like, so you're supposed to be in the right eye, but you give it in the left. That's a significant error. The wrong dosage form, I mentioned this a minute ago. If you give Dilantin, there's different types of Dilantin. Some are extended rate of absorptions versus others. And so if you gave the wrong kind of dosage form, that would be a problem. Wrong medication. And this can happen. There's a lot of look-alike, sound-alike drugs. So the example they give here, they say, well, Tums and Oscal is not significant. That for obvious reasons, right? But
Right.
calcium, but Vibramycin versus vancomycin.
Yeah.
Both sound I said both. I can't even get everything's got a V now. Both sound very familiar, but they're completely different drugs. And then the
Yeah.
last one would be wrong time. This is one that we see quite a bit related to pain meds. So you have a pain med that's supposed to be given maybe after a procedure is done or before a procedure is done, rather. Don't give it till after. That's a problem. Like Caitlin
Mhm.
mentioned a minute ago. And then we move into things that are more, standards of practice, like shaking a medication well. Carafate comes to mind immediately. If you've ever messed around
Yes.
with carafate or sucralfate, whenever you look at the suspension of it, it settles, and you can see if it's in a
Mhm.
amber bottle that we've
Mhm.
dispensed, you can see a white paste
Coding.
looking thing on the bottom of the bottle and then just fluid above it. It takes, and I don't even know, somebody told me this one time, and I think we messed around. I found a study one time, this was years and years ago. How many times does it take that to shake something to get it suspended? Almost like how many licks to the
Forever.
middle of the
Yeah.
lollipop, like, do you get to the middle? It takes a lot. I think it was 20
Mhm.
plus back
Yeah.
and forth, like actuation type deals to be able to suspend the product again. So when you talk about Dilantin, when you talk about Curafate, those medications, if not done correctly, not if you don't shake them well enough, you're pouring the fluid diluent on off the top of the drug and not the drug itself. So what can happen is that they don't have any response to the medication. So sometimes when you see Dilantin being given, they might be increasing the dose, increasing the dose, increasing the dose, but nothing ever changes. Well, that could be because it's not being suspended enough when you're shaking it up before you give it. And then conversely, like what also happens is as you move through the bottle and you use up all the diluent suspension fluid that kind of gets it to the right dose when it's suspended correctly, now you're bolus dosing those patients with the actual drug itself, not suspended. So they get these just gigantic doses of the med.
Mhm.
So, very important to follow
Yep.
manufacturer recommendations, at least shake it, roll it, whatever the case may be, enough times to suspend it. Caitlin mentioned this a minute ago, crushing of meds. It's important to note, she was saying if a manufacturer says don't crush the med, it's an extended release med, something like that, you shouldn't crush it. If a doctor decides to order it differently and says, no, go ahead and crush it, then it's the prescriber's responsibility as well as the pharmacist's responsibility to document in the clinical record why that's okay to do. Okay. So if your doctor out there decides to go against what the manufacturer recommends, which is their own prerogative as a prescribing doctor, whether that's off label indication or giving it a different way than what's indicated, they have to explain the why behind that. Or as a interdisciplinary team, we have to explain that and or find a study that backs the why behind
Right.
that.
Yep.
But G tubes are one of the biggest issues that we see out there. So much that goes into that. Flushing the between meds, you can cut out the flushes before and after and between and certain things like that if they're fluid restricted or very tenuous to fluid. But making sure that you're following the standards for how to give those, not giving them all at once. That's called cocktailing of meds. That went away years and years and years ago. In fact, it even mentions this. It says the standard of practice for giving crush meds should not be combined and given all at once in a feeding tube.
Yep.
So if you're doing that for convenience or whatever, you need to this. No offense, not trying to be raining on anybody's parade. It's just that, that can be very detrimental to the person potentially.
Mhm.
Also, you can't if you go to give it and they say, "Well, I don't want this," you don't know which one to pull out of there at that point in
Right.
time. You can't.
Exactly.
And so we'll link the Aspen Safe Practice Dental Nutrition Guidelines, or try to, in our show notes. So watch for those and you can look at those. But there's so many other things, giving meds with the right amount of fluids. So we would encourage you to look in Appendix PP and see if you can find anything else in there about those.
Yeah, it's long.
Very long,
There's a lot.
very, very long.
Yeah, and I feel like a lot of this stuff you kind of maybe not a lot, but there are some things you learn as you go because it is just so massive. We have so many drugs on the market with different specifications, and they have their own little personalities of how they have to be given. So you just don't ever know like you know, what you're stepping into. And so it is long and it does bleed into other things like we've talked about with standards of practice and evidence-based practice behind some of the medications and things that you can and cannot do that requires research and time to kind of look up and make sure that you're following everything properly. And then, you do have patients that may need some altercations, like, we may need to crush it because there isn't a
Right.
medication substitutable for that, patient. So we get into those types of situations where we have to outweigh benefits versus risk and work together as a team and document, just like Scott's saying. So this is a really massive tag. I mean, it goes in a lot of different avenues.
Yeah. And the last ones that we want to mention here, and I'm so glad Caitlin talked there because she could tell I was dying over here getting
Yep.
drinks of water. It's like
You're
that time of
welcome.
year when yeah, like she can read me like I'm over here about to die. If you're looking on the YouTube, you
Yeah.
see me like grabbing my
Yeah.
taco casa drink, my red solo cup of water drink. I'm like filling all the
Yeah.
drainage running down my back of my throat. But so she saved my life there on that deal.
Yeah.
The other ones that we wanted to mention, obviously, we talked about 756 and 757 drug regimen review, unnecessary meds. Those are two other big areas. One that is not mentioned a lot, but I think we're going to continue to see more is
Oh, yeah.
F605,
Oh, yes.
and that is the free from chemical
Yes.
restraints. As you guys are probably well aware, they shifted all the psychotropics into there. And
Mhm.
now we have, those at risk for being a chemical restraint, making sure
Yep.
that you have stop dates on your PRN, psychotropic agents, making sure that schizophrenia diagnosis is a valid diagnosis.
Mhm.
That's where you see the resident right to be informed. So that's
Yep.
where, prior to initiation or an increase, resident responsible party, resident representative, one of those people has to be informed of that change. Highly recommend that you verse yourself well on that
Yeah.
deficiency and allow for your consultant pharmacist to provide education as well to your teams on that. It is a beast. And in fact, when I first started consulting years and years ago, uh, those were the 2 tags that we saw go kinda hand in hand back then were unnecessary meds because that's where the psychotropics had been shifted back to back then,
Mhm.
and then also chemical restraints. Because again, you cannot be giving a med out of convenience to make them more drowsy or make a resident not, capable of, being fully present on and having, quality of life and living and that kinda thing. So, you don't wanna to restrain the person from their normal behaviors with meds. And so that's the other big one that we were going to see, I think, more. But that's pretty much
Yeah.
it. I think those are the big tags that we see in long-term care as of right now for pharmacy. We welcome any comments, any thoughts, any questions that you guys have in the comment section of our YouTube. Also, we have our contact info at the end of the podcast video on YouTube, so you can check that out. You can email us directly if that's something that you're interested in. But Caitlin, anything else that you can tell our amazing listeners before we jump off here about pharmacy tags and long-term care?
I guess the only thing is this chemical restraint. I see this being a big topic. I don't know if it's maybe just the states that I've been involved in, but it seems to be like that is like hot on the plate. I see survey teams like asking more questions. I can tell by their questions that there's more of a focus with that. So I know like right now it may not flag as one of the top things and it may never because I think that this is kind of where you get a physician involved in documentation and you may have not a full, route that state may be able to go run with it, because if it's well documented, you don't really know how well they can push off of, the physician. But I will have to say that it is a big topic right now. Company that I consult for is definitely gearing their team up for it, making sure those consents are there. A lot more
Mhm.
questions are being asked from staff and from state. So I would advise everybody to just kind of be on the watch out for that and just really make sure documentation is in place. It makes sense. It's within FDA, guidelines as far as like the indications for that drug. If it's not, that we have documentation. And we've talked about this in the past about gradual dose reductions. When consultants ask for those, that is a great opportunity for physicians to provide that extra documentation and clinical rationale, other than just stable, like additional things that maybe they've heard, maybe that they saw during that visit that may not have got onto the paper or onto the electronic chart. So those are just kind of things to keep in mind. I think with collaboration with the consultant pharmacist, it's something that we can definitely help with in ways that maybe you didn't really realize, like those GDR, requests. So I would keep an eye open for that one.
Yeah. Yeah, absolutely. Well, as always, Caitlin and I appreciate every one of you that listen in. We have quite a good listener base, and we continue to hope that the podcast grows and that we get more education out there. So share it amongst your colleagues, your friends in the long term care space. And we look forward to more podcasts coming up in the near future. And so we will see you guys then.